Hello, this is emergency tutorial 1 from cardiac arrest presented by the SchrDbb with reference Harrison Internal Medicine by Dennis Casper et.al. So you're going to start with cardiovascular collapse and sudden death. So what is cardiovascular collapse? It is an unexpected collapse and death due to a ventricular fibrillation. So you need to realize what are definition of certain words. You have what is called ventricular fibrillation. Ventricular fibrillation is impulse transmission into the heart without a syncytial or without an overall contraction of all the heart muscles. It means that what? It means that the heart muscles are contracting individually. That's why you're going to have fibrillations. You don't have an effective contraction of the heart. You instead have the individual contraction of each of the different heart muscle cells. So that's why it's going to cause fibrillation. And this fibrillation is going to usually present with a pulseless electrical activity, and the best way to treat it is going to be by cardioversion. So that is what is defined as sudden cardiac death, something like that. So we have management of cardiac arrest. So you need to know that every time you have a patient that has a cardiac arrest in front of you, the first thing that you have to do is cardioversion. Do cardioversion by an electrical external defibrillator. That's the thing that is very important. Second one, if respiratory stridor is present, assess aspiration of the foreign body. You can have a cardiac arrest. It may not be, if it's not a cardiac arrest, it may be somebody has aspirated the foreign body, and you have to do the Heimlich maneuver, meaning that you place yourself in the back of the patient, and then you place your thumb toward the sternum of the patient, and then you press the patient towards yourself with your thumb. So the next one, you have cardiac arrest, the table. What are the things, cardiac arrest and the sudden cardiac death? These are the different causes of cardiac arrest. You have structural abnormalities, you have functional abnormalities of cardiac arrest. The structural abnormality that can cause cardiac arrest, you have coronary heart disease. So coronary heart disease can cause cardiac arrest. You need to know that the main pathophysiology under cardiac arrest or a cardiac attack is an arrhythmia. So when you have an arrhythmic pulsation of the heart, anything that can cause an arrhythmia is capable of causing a sudden cardiac death or cardiac arrest or even a heart attack. So these are the different things here. So we have cardiac arrest and sudden cardiac death can come as a result of association of causes. So you have what? You have coronary heart disease, you have myocardial hypertrophy, that's hypertrophic cardiomyopathy, you have dilated cardiomyopathy, you have inflammatory causes like myocarditis and infiltrative disorders, you have valvular heart disease, electrophysiologic abnormalities such as Wolff-Parkinson-White syndrome, and you have inherited disorder with electrophysiological abnormalities such as congenital lung Curtis syndrome, you have the right ventricular dysplasia, Brugada syndrome, and the different ones. Now, under functional contributing factors, so if you have transient ischemia of the heart, it may cause you cardiac arrest. If you have low cardiac output state, it may cause cardiac arrest, like heart failure. If you have systemic metabolic disorder, electrolyte imbalance, mostly hypokalemia, hypoxemia and acidosis, neurologic disturbance, and toxic responses. So those are the causes. So every time you have a patient that has a heart attack in front of you, this is a maneuver that you have to do. A maneuver is called cardiopulmonary resuscitation. The first step is to come toward the patient. You press for every 3 contraction, for every 3 compression, you do 1 rescue breath. For every 3 compressions, you do 1 rescue breath. So you have to do 4 activities within 2 seconds. So in 1 minute, you must have done 90 compressions and you must have done 30 rescue breaths. So those are the elements. So every time you have a patient that has a ventricular fibrillation usually presents as a pulseless electrical activity. You feel the pulse, you have anything, but you have something on the electrocardiogram. So that's what is why it's called pulseless and ventricular tachycardia. So we have immediate fibrillation. So if you have this ventricular fibrillation, so you are going to do immediate defibrillation within 5 minutes of onset. So 60 to 90 seconds of cardiopulmonary. You can start with 60 to 90 seconds of cardiopulmonary resuscitation before defibrillation. Delay greater than 5 minutes. So those are the points. So that's the next thing that you're doing after the defibrillation. 2 minutes of chest compressions at more than 100 compression per minute, followed by a repeat shock and repeat sequence twice if needed. Then the next thing is to continue the chest compression and intubate with IV access. So the first point is to start with defibrillation. If you have already done cardiopulmonary, you delay for 60 to 90 minutes of chest compression before defibrillation for delay of greater than 5 minutes. If you have delayed the cardiopulmonary resuscitation, the defibrillation for more than 5 minutes, you need to do cardiopulmonary resuscitation for 60 to 90 minutes before you start defibrillation. The next step, 2 minutes. When you have done defibrillation, you have now to continue now with the chest compression for 2 minutes, with each compression having 100 compression per minute. Then you do again another repeat shock and repeat sequence twice if needed. But if it is not still positive, you continue with the chest compression, you intubate the patient with IV access. So now IV access, now why do you need now epinephrine? Epinephrine is going to become as a chronotropic effect. It's going to do a chronotropic effect on the heart, such that the heart is capable of pumping. Because you have a pulseless electrical activity, you want to activate the heart so that it pumps. So epinephrine is going to help, or vasopressin, so those are the elements. So after that, if there is no return, if the return to circulation fails, you have to increase the dose of epinephrine. You use an antiarrhythmic provided that there is arrhythmia. Antiarrhythmics are also used in cardioversion, but they are mostly used, they are called chemical cardioverters or pharmacology cardioverters. Now in case where the patient has acidosis, you can use sodium hydrogen carbonate. Acidosis has been the functional cause of the heart attack. You can use sodium hydrogen carbonate, or you can use potassium, increase the potassium level. Because in cases of hypokalemia, as another functional cause of heart attack, we had cardiac arrest. Now, example now of antiarrhythmics. You are going to see later that there are 4 classes of antiarrhythmics. We have class 1, which are sodium ion channel blockers. We have class 2, which are beta blockers. You have class 3, which are potassium ion channel blockers, and you have class 4, which are calcium ion channel blocker, and they are known dihydropyridines. So those calcium ion channel blockers are known dihydropyridines. So this one is a potassium ion channel blocker. I'm not that one. Lidocaine is a sodium ion channel blocker, and then so those are the things that you can use. The other one that you can use magnesium sulfate and procainamide. So those are the steps that you have to do to perform when you have a case where you have a ventricular tachycardia with a pulseless electrical activity. Now, if you have asystole, so you have already seen for pulseless electrical activity the steps that you are going to follow. But in case of an asystole, you have to start with the CPR. After starting, you confirm the asystole. How can you confirm the asystole? You can confirm the asystole or bradyarrhythmia by using an ECG. After confirming with an ECG, you have to identify and treat the cause of the asystole. But you need to know that in asystole is not the same as ventricular tachycardia. In asystole or ventricular bradycardia, you have a reduced heart rate, while in ventricular tachycardia you have an increased heart rate, so it may result in fibrillation. Now in asystole, you should not do defibrillation. We defibrillate if you have an excessive heart rate such that the heart rate goes to normal. But if you have low heart rate, don't defibrillate. Instead, you need to activate the heart. And you activate the heart, the major treatment in the assistor is going to be this, which is an external pacemaker. It's an external pacemaker that is being placed, shows that it increases the activity of the heart. But before you place the external pacemaker, you have to identify and treat the cause. That is, the hypoxia can cause the assistor. Hypokalemia or hyperkalemia can cause the assistor, but best hyperkalemia. You have severe acidosis. Severe acidosis can result to hyperkalemia, that can result to assistor. You have drug overdose. Some drugs are capable of resulting to hyperkalemia. An example of those drugs include digoxin. We have hypokalemia, and other drugs we also have beta agonists that can cause hyperkalemia. We have hypothermia. So those are the drugs which are being used here. In case of where you have, so the causes now of excessive ventricular. So if you have hypovolemia, the heart is going to try to pump so fast. We have hypoxia. 2, tamponade. So we have pneumonia, we have hypothermia. So anything is going to try to increase the heart rate is going to result to an increased electrical activity that may result to a pulseless activity. You need to know that when the heart rate is greater than 150 beats per minute, it becomes pulseless. There is a reduction in blood flow to the systemic circulation. So the next thing is the follow-up. What is the follow-up of the patient that you need to do? If cardiac arrest resulted from ventricular fibrillation in the initial hour of an acute myocardial infarction, follow-up is standard post-myocardial care, myocardial infarction care. So if you have a patient who had a cardiac arrest or a ventricular fibrillation as a result of an acute myocardial infarction, you need to do a good follow-up. For the other survivors of ventricular fibrillation arrest, further assessment needs to be done, including evaluation of the coronary anatomy. So you evaluate each of the coronary anatomy with the coronary angiography, and if there's any disorder in each of the coronary anatomy, you need to do balloon stent and dilatation. So balloon dilatation and stenting, such that it should not reoccur. And there are other causes in the follow-up that you need to take consideration of. We said initially here that we had myocardial hypertrophy. So myocardial like hypertrophy, cardiomyopathy, dilated cardiomyopathy. You need to treat the underlying cause either pharmacologically or surgically in order to inhibit or reduce the remittance. Thanks for your kind attention.